So welcome and good afternoon to the IRCnet webinar. The subject of this webinar is the KDIGO guideline on immune-mediated glomerulopathies, and we're going to focus on minimal change disease and membranous nephropathy. And I'm very welcome and very happy to introduce Professor JackWetzels, which will be giving the webinar this afternoon. Welcome, Jack. And I wanted to give a brief introduction of this very eminent speaker that we are lucky to have with us this afternoon. JackWetzels is now Emeritus Professor of Nephrology, and he is at the Radboud University of Nijmegen. And he studied from 1990 to 1992 ischemic renal tubular injury as a postdoc under the supervision of Robert Schreier at the University of Colorado. Since 1992, he has worked as a nephrologist, and then in 2002, he became a professor of nephrology. His chair was committed to teaching and research, especially with an emphasis on the diagnosis and treatment of glomerular diseases. He is supervisor of the Radboud Expert Center for Rare Kidney Diseases, co-chair of the IRCnet Working Group on Immune Glomerulopathies, and member of the expert group that was involved in writing the KDIGO guidelines on glomerular disease. So it's a great pleasure to welcome you, Jack, and I'm looking forward to a great webinar. Thank you for being here.
Thank you, Marina, for this introduction, and welcome to the audience. And I'm going to cover the KDIGO guidelines with respect to membranous nephropathy and minimal change disease and FSGS. So the guidelines were recently published after a period of almost 3.5 years of preparation and discussion. And before starting this webinar, I have 2 questions I would like to pose. The first question is, if you as audience did already study the chapters on membranous nephropathy and minimal change FSGS in the 2021 KDIGO guideline. And you can just select one of the answers very quickly. Okay, I can see the answers, and I can see it's almost even. So a small majority studied the guidelines. Okay, thank you. Then the next question, to get some idea about your work, your daily work. How many patients with active membranous nephropathy or minimal change disease FSGS are in your care? Active meaning patients who are, followed for proteinuria or have been treated recently or are currently treated with immunosuppressive therapies. Okay, well, this is very nice. So the audience is very mixed from, let's say, more and less people taking care of these patients. Well, thank you very much. Okay, we will go, and I will, in this webinar, I will tell you about the content of the KDIGO guidelines regarding membranous nephropathy and minimal change FSGS, and I also will address something which is not ready in the guideline, but I want to talk something about the role of PLA2R antibody measurements in patients with membranous nephropathy. And those who have read the guidelines already have seen that most of the recommendations are based on limited evidence. That's always with rare kidney diseases. There are few randomized control trials, so you cannot make recommendations with hard evidence. And that's why many of the recommendations which used to be graded X are now called practice points. So it's more expert opinion based on limited evidence. You all know that membranous nephropathy is an immune-mediated disease, first described in 1957, and the clinical course is quite variable. Some patients developing spontaneous remission, but others progressing to end-stage renal disease. And actually, in 1995, the group of Ponticelli published the results of a randomized control trial with 10-year follow-up showing that treatment with alkylating agents improved outcome. And in this slide, you can see that with treatment with alkylating agents, very few patients progress to end-stage renal disease. But you can also see that untreated patients, almost more than half of the untreated patients did not develop end-stage renal disease, indicating that the prognosis is very variable, but that a large subgroup of patients actually do not need immunosuppressive therapy. Obviously, treatment with alkylating agents is very toxic, associated with many side effects. So the choice has to be, can we improve therapy? And also, can we predict patients who are going to develop spontaneous remission? In 2009, there was a great breakthrough with the discovery of PLA2R antibodies in more than 70% of patients with primary membranous nephropathy. And it is now clear that these PLA2R antibodies are quite sensitive and specific for the diagnosis. And this has resulted in the fact that in the guideline, it is now stated that PLA2R antibodies can be used as a very specific biomarker for a diagnosis of membranous nephropathy, meaning that in patients with a nephrotic syndrome where you have antibodies present, that you don't need to do a biopsy to diagnose membranous nephropathy. Obviously, there are situations where you still have to do a biopsy, and this is particularly the case if the patient has an unusual clinical course, for instance, presentation with acute kidney injury, where you could find in the biopsy alternative diagnosis such as tubular interstitial nephritis. But it's important that at this time, you don't need to do a kidney biopsy to diagnose membranous nephropathy. So that's a very important step forwards. When measuring these PLA2R antibodies, we usually use an immunofluorescence technique or an ELISA technique. And in the ELISA, a cutoff of 14 units per ml is used. We must realize that the immunofluorescence technique is more sensitive than the ELISA technique, meaning that if you have patients with a titer below 14 in the ELISA, you still should consider to do an immunofluorescence test to see whether that's positive and confirms the diagnosis of membranous nephropathy. With respect to treatment, all patients with membranous nephropathy, like other patients with proteinuria, should be treated with supportive therapy, aiming at reducing blood pressure, reducing proteinuria, taking care of hyperlipidemia, and adhering to lifestyle matters such as non-smoking, doing exercise, and reducing dietary sodium intake. In patients who are non-nephrotic, there is no need to consider immunosuppressive therapy. You can just maintain regular follow-up visit because patients with non-nephrotic proteinuria will not progress. If they progress, it's always after a phase of nephrotic syndrome. In patients who present with membranous nephropathy and a nephrotic syndrome, you should start to evaluate the risk. And there are two important points to consider. First, you should try to evaluate the risk to develop arterial and venous thrombosis. And the next is to evaluate the risk for kidney disease progression, meaning progressive kidney disease ending up with kidney failure. The first point, arterial and venous thrombosis, is very important because we know that patients with nephrotic syndrome are at risk for venous and arterial thrombosis, and the risk is highest in patients who have membranous nephropathy. So in the guideline, there is a practice point on anticoagulant therapy in patients with membranous nephropathy. And in this algorithm, it's important that we use serum albumin as a cutoff value to define patients at highest risk. And to the left in this diagram, you can see that different cutoff values are used depending on the serum albumin assay. And that's, I think, an important point to consider, that there are differences between these assays and that some assays give you a 5 to 7 grams higher value than other assays. So in using cutoff, you would have to take into account the assay that is used in your hospital. The next step is that you have to estimate the risk of thrombosis, but also the risk of bleeding. And that's important because if you consider the use of prophylactic anticoagulant therapy, you would like to prevent thrombosis, but you don't want to get bleeding. So there are tools on the internet to assess the bleeding risks. And then based on this estimate, you have to decide whether you want to use anticoagulant therapy. What is also important in this, in the new guideline, is that not only we took into account the risk of venous thrombosis, but we also consider that patients with nephrotic syndrome are especially at high risk for arterial thrombotic events, such as myocardial infarction or cerebrovascular accident. So in this algorithm, there now is also a place for use of aspirin in patients where the risk for venous thrombosis is considered too low to start anticoagulant therapy with warfarin or low molecular weight heparin, but still sufficient to have a risk of arterial events. And in that case, we should use aspirin monotherapy. Then when looking at the prophylactic treatment, there is a choice between warfarin or a combination of prophylactic low molecular weight heparin and aspirin. And I think the choice is based on individual patient characteristics. What is important to consider is that if you start warfarin, you have in the initial days a higher risk of thrombosis because of the different kinetics between the procoagulant and anticoagulant factors. So that's one of the reasons that I like to start with low molecular weight heparin and just take over with warfarin later on. And what is also important is that the risk of thrombosis is very high in the initial phase of the nephrotic syndrome. And if you consider starting treatment with steroids, you should realize that there is some evidence that high steroid pulses are thrombogenic. So if you start treatment, you should not, let's say, not give anticoagulant treatment. It's rather important to start anticoagulant treatment before you start treatment. So that's one important step in the conservative treatment. Try to consider anticoagulant therapy in each patient with membranous nephropathy, and do it as soon as they present, because the highest risk of thrombosis is in the initial phase. The next step is to predict the risk of progressive kidney disease, because patients can develop spontaneous remission, can develop kidney failure, and it's important to estimate the risk and to use that risk estimate in the decisions to start immunosuppressive therapy. And if we look at risk prediction, then it's still clear that the most important and strong risk predictors are serum creatinine, proteinuria, and serum albumin. But we use also some additional markers, such as the duration of proteinuria. There's a risk score which you can use based on magnitude of proteinuria and change in creatinine clearance over a time period of 6 months. We use urinary excretion of low molecular weight proteins, and you can also consider PLA2R antibody levels. For instance, in the right of the slide, there is the high risk category based on having proteinuria for more than 6 months in the nephrotic range and no decrease in proteinuria. And then you can use one of the risk markers which would help you to define these patients as having additional risk. And based on these criteria, we categorize patients with membranous nephropathy in 4 categories: low risk categories, moderate risk, high risk, and very high risk. The low risk categories are the patients who have non-nephrotic proteinuria and normal GFR, or normal GFR and proteinuria which has been decreasing in the 6 months of follow-up. To the right, we have the very high risk patients, and that's the patients with already deterioration of kidney function or what we call life-threatening nephrotic syndrome. So you can see that using various criteria, we define these 4 risk categories. Obviously, in this risk estimate, the follow-up of the patient is very important. So if you have a patient and you see the patient every 2 to 3 months, then obviously the change in serum creatinine, in proteinuria, and serum albumin, and in these risk markers is important to consider. Increasing proteinuria predicts a worse prognosis, whereas a decrease in proteinuria suggests the patient could be developing spontaneous remission. Based on these risk categories, we have to choose treatment. And what is the possibility of treatment in patients with membranous nephropathy? And in the last, I would say 5 to 10 years, we have seen a couple of randomized controlled trials. And what did we learn from these trials? Well, there's one trial, the HEMRITUX trial from France, which compared rituximab with conservative therapy. And this trial showed that rituximab induced more remissions than placebo, but still 35% of patients did not respond to rituximab. And there was a high remission rate in the placebo group, suggesting that the old KDIGO guidelines for risk prediction were not sufficient. And that's the reason that we now have these additional markers, hoping that it would allow you to better predict the risk of patients and select the patients who are going to develop spontaneous remission. The next randomized control was the MENTOR study from the US and Canada that compared rituximab with cyclosporine. And the initial response in the first 12 months was similar. The remission rate was approximately 60%. But after withdrawal of cyclosporine and not continuing rituximab, there were more persistent remissions with rituximab. Then we have the combined rituximab studies from the Bergamo group, and the HEMRITUX and the MENTOR. And overall, these studies showed that 35% of patients did not respond to rituximab monotherapy. The STARMAN trial, conducted mainly in Spain, compared tacrolimus followed by sequential therapy with 1 gram of rituximab, compared it with the Ponticelli regimen of cyclotol, cyclophosphamide, and steroids. And this trial showed that cyclophosphamide induced more remissions than tacrolimus rituximab. Still, tacrolimus induced remission in 60% of the patients, and the use of rituximab prevented the relapse, which are commonly seen after CNI withdrawal. So there's almost 60% persistent remissions. And then we have the last trial, the ReCyclo trial from Italy, that compared rituximab versus cyclophosphamide and steroids, and the study concluded that rituximab was not inferior to cyclophosphamide. However, the study was underpowered. It was actually started as a pilot study. It only included moderate risk patients, and the subgroup analysis suggested superiority of cyclophosphamide in higher risk patients. So you can see that all these treatments have effects. They are able to induce remissions, but the patients with the highest risk do not respond to CNI or rituximab. And based on that evidence, the treatment is the choice of treatment is depicted in this slide, and you can see that here we have again these 4 risk categories. The patients at low risk, you should not use immunosuppressive therapy. The patients with moderate risk, you can choose a wait-and-see policy because some of them still will develop spontaneous remission, or you can use rituximab monotherapy, or you can use a calcineurin inhibitor with or without steroid added to it. The high-risk patients, you can choose between rituximab or cyclophosphamide and steroids, or calcineurin inhibitor and rituximab. And in only the very high-risk patients, there is the choice to start with cyclophosphamide and steroids, because in these high-risk patients, neither rituximab monotherapy nor CNI therapy are effective. So you can make a choice on various possibilities defined by the risk classification, but also even within a risk category, you can choose between various drugs depending on what is available, what is the side effects expected in the individual patients, etc. Obviously, although we try to treat the patients, not all patients respond to current therapies, and in this algorithm, it's actually shown that if the patient doesn't respond to the first, you can try the alternative. So you can, if the patient doesn't return to cyclophosphamide, you can add rituximab, etc. In the end, there are still 5 to 10% of the patients who do not respond to the currently available drugs, and then we suggest to consult an expert center, and there people will be available who can think about using newer drugs like plasma cell-directed therapy. But for now, I think this should only be done in studies, in clinical studies or in expert centers. One point I would like to make is the assessment of kidney transplantation in membranous nephropathy. Obviously, with the current effective treatment, kidney transplant in membranous nephropathy is declining. So we see fewer patients with membranous nephropathy as original kidney disease. Still, if you have a patient with membranous nephropathy with end-stage renal disease and you consider kidney transplantation, it's important to try to define whether the membranous nephropathy is PLA2R antibody associated, because if the patient has antibodies at the time of transplant, the risk of recurrence is pretty high. If the patient has PLA2R antibody associated membranous nephropathy, but the antibodies have disappeared, the risk of recurrence is very low. In this study, it's important to realize that if the antibodies are not present at the time of transplantation or the screening for transplantation, and you don't have old data, it's very difficult to know whether the patient has PLA2R antibody associated membranous nephropathy and the antibodies have disappeared, or whether it's a membranous nephropathy not associated with PLA2R antibodies. And that in this circumstance is very important to try to retrieve the native kidney, because you can try to stain for PLA2R antigen, and if the staining is positive, you know that the membranous nephropathy is associated with PLA2R antigen, and that negative antibodies means that the antibodies have disappeared. So that's an important point where we can try to estimate the risk for recurrence based on knowledge on antibodies and the presence at the time of transplant screening. Talking about these antibodies, it's not yet in the guideline, because guidelines, you know, they are written based on evidence from 1 year ago or 2 years ago. But obviously, with these antibodies, we know right now we know already more. So we know that we can measure the antibodies in the serum and detect the antigen in the kidney biopsy. We know that the biopsy is most sensitive. So with the detection of the antigen in the biopsy is more sensitive than measuring antibodies in the serum. And if you measure antibodies in the serum, the ELISA is the least sensitive technique, but still ELISA provides quantitative levels. So it tells you something about the level of antibodies. It's important to realize that in the beginning of the disease, antibodies can be absent in patients with PLA2R associated membranous nephropathy, and probably that's caused by the fact that the antibodies are bound to the podocytes and not yet present in the serum. So the kidney functions as a sink. And it's important that in such a case, if you are not able to stain the biopsy for the antigen, to repeat the measurement of the antibodies after a period of, let's say, 3 months. Obviously, if the patient presents and has already a history of edema for a longer time, and you cannot find the antibodies, then it also could be that the patient is already going into immunological remission, because we know that disappearance of the antibodies can occur 3 to 6 months before the disappearance of proteinuria. And also in this case, it would be very important to stain a kidney biopsy, because in that case you would prove that the membranous nephropathy is associated with PLA2R antigen. There's a very weak correlation between the level of the antibodies and proteinuria, and there's some discussion whether we should measure IgG4 or total IgG antibody levels. I think that's still open for debate. What have we learned with these measurements? Well, I already showed you that kidney biopsy is no longer needed to diagnose membranous nephropathy, but obviously the question was and is if the antibody levels can be used as prognostic or predictive biomarker and can help us to guide therapy. And I specifically mention here prognostic and predictive biomarkers because that's often confusing. And it's important to realize that according to the definition used by the FDA, a prognostic biomarker is a biomarker which allows you to predict the course in an untreated patient. So it tells you something about the natural course of the disease. A predictive biomarker, in contrast, is a biomarker which allows you to predict the response to therapy. So it's totally different, and that's important. And the literature on PLA2R often has been, let's say, difficult to read because there is no clear definition between this use of PLA2R antibodies as prognostic or predictive biomarker. Well, first look at PLA2R as prognostic biomarker. This is a study in patients with membranous nephropathy, normal serum creatinine, where patients either had spontaneous remission or progression, and progression meaning needing immunosuppressive therapy because of deteriorating eGFR. And then you can see that although there is a difference in antibody levels, with antibodies being higher in the patients who progressed, clearly there is a large overlap. And in fact, in this study, there was no, in multivariable analysis, there was no real added value of PLA2R antibodies over serum creatinine and proteinuria. On the other hand, PLA2R antibody levels seem to be very useful as predictive biomarker. This is from the rituximab study from the group from Pepper Rimuzzi, and this is the remission rate in patients treated with rituximab. And here you can see that patients with in the lowest tertile of PLA2R antibody levels had a very high remission rate, whereas patients in the highest tertile, the remission rate was only 30 to 35%, indicating that here in this situation, it is important to have information on the level of the antibodies because you can use it to decide whether you would use this therapy and also to see if you would change the therapy if patients are not responding quickly. The same is true for, let's say, evaluation of response to therapy. If you treat the patients, and in this case, these patients were treated with cyclophosphamide for 6 to 12 months, the patients who responded and became PLA2R negative, they had a relatively good outcome and with some relapses, but still overall, they remained in remission for a long time. Patients who at the end of treatment were antibody positive actually had a very poor relapse-free survival. So all these patients needed other treatment. So it means that actually if you treat patients, it's important to realize that immunological remission should be the goal. So can we use it to guide therapy? The guideline tells you that it's important to measure the antibodies after 6 months. And personally, I think we already have some data to suggest that you could start measuring after 3 months, because between 3 and 6 months, there is not much added value, I think. So most patients who respond already attain the response after 3 months. But if you measure the antibodies, they should be gone. And if they are not disappearing, then you could choose to change and add alternative therapy. And I think that's important because we know that it can take 12 months or even more before a patient develops partial or complete remission. So by measuring these antibodies, you can already predict whether these patients will eventually respond, and you can change your therapy without delay, I would say. Lastly, with respect to membranous nephropathy, PLA2R antibodies are very important. Meanwhile, this is a list of the new antibodies, and I have not been able to add TGFB receptor, but at this mind, that's the latest antigen. But we have many new antigens, although if you look at these studies, very few patients have these new antigens. There is a discussion whether these antigens are really relevant. Some of these antigens, there are no antibodies found in the circulation. It's also interesting to see that many of these antigens were associated with antibodies of the IgG1 and not IgG4 subclass. And also some of these antibodies are clearly associated with underlying diseases, such as NAL1, which is associated with malignancies, exostosin and NCAM, which are associated with lupus, for instance. So I think the coming decade, we expect more to hear about these new antigens. For now, they cannot be used like PLA2R. Then we are switching gears and are going to minimal change in FSGS, and where the guideline on membranous nephropathy has seen, I would say, many changes, especially because of the discovery of the PLA2R antibodies. With respect to minimal changes in FSGS, it's much more difficult. We still do not exactly know the cause. There is no specific biomarker for these diseases. So not much change. For minimal change disease, actually, it's quite simple. We still treat these patients with corticosteroids. And if there are contraindications to corticosteroids, you can use alternative agents. And I would say there are many possibilities. The most recent studies suggest that you can use induction therapy with a short period of steroids, like 10 days, added with tacrolimus monotherapy. And in my experience, in elderly patients, that's working pretty well. If patients with minimal change disease relapse, you can, again, the first relapse treat with prednisone, but there are alternatives available in adult patients. And if they are frequently relapsing, you can choose between various drugs. In this algorithm, cyclophosphamide is still prominent since adults can be treated for 12 weeks with cyclophosphamide with a relative low risk, and then they are most of the time relapse free for at least 2 to 5 years. But in patients who do not tolerate cyclophosphamide or do not want to have cyclophosphamide, you can choose between these other drugs, although I must say that many of these you need to give continuously to maintain a remission. So you have to treat these patients for at least 2 years to keep them in remission. I think for focal segmental glomerulosclerosis, it's important to realize that the guideline starts with discussing the differential diagnosis. Since FSGS is not a disease, it's a histological description of a picture characterized by sclerosis. But it's important to realize that there are many causes of FSGS, and in the guideline we have the primary FSGS, which is the form of FSGS characterized by a rapid onset nephrotic syndrome, diffuse food process effacement on electron microscopy, probably caused by a circulating factor and often responding to treatment. Other causes of or other forms of FSGS are the genetic forms, which are in adults most often autosomal dominant, can present with a nephrotic syndrome, but often have a very slowly developing course of slowly progressive proteinuria. We know the well-known form of secondary maladaptive FSGS, which is seen in patients who have lost nephrons due to injury or born with a low number of nephrons. But also we have secondary causes of FSGS due to, for instance, viral infections or drugs. And that's important because viral infection and drugs can induce very rapid podocyte injury and cause also a nephrotic syndrome. In contrast, the adaptive form of secondary FSGS, so the form caused by hyperfiltration, I would say almost never have a nephrotic syndrome. They have nephrotic range proteinuria, but normally serum albumin is above 30 grams per liter. In the guideline, a fourth category was added, and this is the category of FSGS of undetermined cause. And this was added because in many patients with a clinical picture which is suggestive of a maladaptive response, so they present with nephrotic range proteinuria, but no nephrotic syndrome, with only segmental food process effacements, so no diffuse food process effacements. In some of these patients, no real underlying cause of kidney injury could be found. And in the past, this led these patients to be diagnosed as FSGS, idiopathic FSGS, but these patients then also were treated with steroids, and that should not be done. A patient with FSGS with segmental food process effacements, not nephrotic, that's not primary FSGS. So that is a patient who should not receive immunosuppressive therapy. This patient should be considered as having a maladaptive form of FSGS. Maybe also genetic forms could be there and the gene has not been found yet. So this is very important to consider these four categories. And with respect to treatment, only primary FSGS is amenable to treatment with immunosuppressive therapy. And this is what the management looks like. If you have a patient with FSGS on kidney biopsy and there is no nephrotic syndrome, then you should evaluate for other underlying causes, including genetic screening. And in the guideline, there is a nice table when you should consider genetic screening, but in adults, it's often autosomal dominant, so some first-grade relatives have some proteinuria, but this patient should not receive immunosuppressive therapy. If the patient develops or presents with nephrotic syndrome, then if you confirm that there is diffuse food process effacements, you could consider this patient as having likely primary FSGS, and then the patient could be treated with immunosuppressive therapy. But still, if there is no response, we should, or again, go back and consider other causes. And this is the problem. Although many patients with primary FSGS respond to steroids, it's not an easy treatment. And I would like to close with two observations. One is the fact that since there is no biomarker, you can question whether minimal change disease and primary FSGS are really different diseases. And second, if you treat patients with FSGS, you should realize that it takes a long time. First, this is a theory we have developed based on the fact that we think that maybe minimal change disease and FSGS are actually forms of a similar injury to the podocyte, but that differences in the intensity of podocyte injury, but also differences in the number of podocytes and differences in, let's say, the genetic buildup of the podocytes, making the podocyte more or less vulnerable to injury, could explain differences between these pictures. And actually, there are patients, and we know it from recurrent FSGS, that they start with a minimal change disease picture, light microscopy, and then they can develop a tip variant of FSGS or FSGS NOS with sclerosis. So it's more or less a continuum based on maybe the severity and of the podocyte injury, the loss of podocytes, and the resistance of the podocyte to the injury. In terms of treatment, both minimal change and primary FSGS are treated with, for instance, corticosteroids. And finally, to conclude, I show you some of our data on the treatment of FSGS. And this is a study where we included patients with primary FSGS. So we selected only patients who had evidence of diffuse food process effacement, clear nephrotic syndrome, negative family history, normal sized kidneys. And we selected the patients who did not have complete remission after 8 weeks, which sometimes is used steroid resistance. Actually, when we went back we had only 2 patients out of 53 who had a complete remission after 8 weeks of prednisone, showing that adults with primary FSGS are not very responsive. The 51 patients who did not have complete remission after 8 weeks were followed, and these patients had an average age of 47 years, a little bit more males than females, and they had a reasonable kidney function with a serum creatinine of 94 micromoles per liter, eGFR of 77 milliliters per minute, and a low serum albumin of 21 grams per liter, so clearly showing that these were all nephrotics. If you then look at the response to corticosteroids, then at 8 weeks, as defined, there was no patient in complete remission. At 16 weeks, still no patient in complete remission. So the definition steroid resistance and the discussion whether it should be at 8 or 16 weeks, in my personal opinion, is a discussion which is not very useful, because these patients do not develop complete remission within 16 weeks. You can see that the number of patients in partial remission is growing, but it keeps on continuing, and patients who are being treated for more than 24 weeks, finally 27 out of 51 reached complete or partial remission, but still many non-responders. Obviously, this is a retrospective study, so what happened to these patients is that many of them were treated with added immunosuppressive therapy, like cyclophosphamide or calcineurin inhibitors. And in the end, the main conclusion is that we had 8 patients with primary non-response, 5 patients with secondary non-response, but meaning that the majority of patients in the end developed a partial or complete remission of proteinuria, but the average duration of immunosuppressive therapy was more than 1 year. So that's I think a very important point. You can reach remission, but you need to treat for a long time. But unfortunately, some patients never respond, and we are not able yet to select these patients. What we in retrospect did see, and what, well, is interesting, but should be validated, but when we look back, the patients who did not respond had no decrease in proteinuria of more than 20% after 8 weeks, whereas the patients who later on developed remission, almost all of them had more than 20% decrease in proteinuria after 8 weeks of therapy. So we hope that by following the patients in the beginning of the therapy and looking at proteinuria, that this might enable to at least select the patients who are going to respond. And these patients, you should continue the treatment. So this is from my last slide, and this is from a recent comment of De Classic and Fernando Fervenza, and showing how you could address the treatment of patients with FSGS to the left. And I have changed it a little bit because I'm not confident that's yeah, I think it could be a little bit improved. But to the right, you can see that if the patient is nephrotic, has an FSGS lesion, and has food process effacement, and you cannot find an underlying cause, you can consider it primary FSGS. You can start prednisone and then treat for 8 weeks. If after 8 weeks there is more than 20% reduction in proteinuria, you should continue therapy. There's a high chance that the patient will develop remission, but it takes time. So you have to realize that you could be treating the patient for more than 1 year. And personally, I think after 8 weeks, you should see whether you change the steroid for another drug or use combination therapy, especially if patients have side effects of steroids. If there is after 8 weeks, there is less than 20% reduction in proteinuria, I think you can take 2 possibilities, or you have 2 ways to go. One, start with genetic testing, and if there is negative, there's no mutation, start with CNI therapy. The alternative, and that's also I think not implausible, is that you just say, okay, I start CNI. If there's a good response, it's fine. If there's no response, I do the genetic testing. So this could be something to consider. But obviously, bear in mind, this is not yet in the guideline, but I would like to show you that treatment of rare kidney diseases is a continuous process, and at the moment the guidelines are published, there are almost, for at least for part, they are already outdated. This ends my presentation. I'm open for questions, and I present the last slide showing already the next webinars which are coming. Thank you very much.
Thank you, Jack. I think that was really, really excellent. And you have a ton of questions. So we have about 15 minutes. So I'm going to try to go through. And there's some of you, there's one specific physician who has asked lots and lots of questions. So to try to be a bit par condicio, I'm going to hop back and forth to give everyone a chance to ask their questions. So the first question that arrived is about the use of other anti-CD20 monoclonal antibodies in membranous nephropathy and also in minimal change instead of rituximab, such as, for example, obinutuzumab. Yep. And Dr. Ramadan made this question.
Yes, well, I think it's a very good question. I'm sure that at the moment we already think that obinutuzumab is more let's say effective than rituximab, so I expect that in future trials it will be shown that it is more effective and could be used, and maybe it also we have to see whether the 35% non-response to rituximab, that non-response rate will be lower with obinutuzumab. So I'm sure, but yeah, unfortunately, we only have anecdotal data, some case reports, but no firm studies. But I expect that we will see trials coming out in the next years showing how obinutuzumab will work. And I think the most important point is that we need to try to see if we can reduce the number of non-responders, because that's at the moment, I think, the difficulty with the current new treatments. We have this group of 30% of patients who do not respond very well to either CNI or rituximab, even for doses like the Mentor study, and these patients now are treated with cyclophosphamide and steroids, and I hope that the newer anti-B cell therapies could offer improvements, and we could see that this non-response rate is reduced.
Okay, great. I'll try to connect with that. There are other two questions regarding the use of anti-CD20 in membranous, in particular rituximab. So Dr. Rudnicki has asked, what about like if you can comment on the loss of rituximab in a patient that has heavy proteinuria into the urine, and what to do in these cases, if rituximab should be given more often, or should we check if the CD20 depletion has been complete, as is done in other diseases like ANCA-associated vasculitis?
Yeah, so obviously there are data showing that rituximab is lost in the urine. We also know that if you measure rituximab levels after 3 and 6 months, that the patients who have the lowest level after 3 and 6 months are less likely to have persistent remission. We also know that measuring B cells is maybe not very helpful. The Mentor trial used 2 doses of 1 gram at baseline and then repeated this at 6 months, and they had almost complete B cell depletion, I would say, at least below the level of 5 cells per nanoliter. And I think that measuring B cells in the peripheral blood is insufficient. So what my message is that 4 grams of rituximab might not be enough, but we don't know what we can use to measure it. So that's why actually I like personally the Starman regimen, where we started with the tacrolimus, which reduces proteinuria in many patients with membranous nephropathy, either by having a direct podocyte effect, and then after 6 months, these patients received 1 dose of rituximab, and that gave a response rate which was comparable to the response rate in the mentor trial. And we also didn't see the relapses which were seen with CNI withdrawal and other studies. So that could be interesting, and especially I have used that now a lot in this era of COVID infections, because tacrolimus, in my view, is I would say the least dangerous drug in a patient who is likely to catch COVID. Whereas rituximab, you have no antibody response to vaccination, you have no antibody response to the COVID virus itself. So I think that could be a strategy. I hope that in the future more let's say strict B-cell depletion with like obinutuzumab would help us, and we don't need to consider failures of rituximab.
Yeah, great. That's actually really, really interesting. The idea of reducing proteinuria before you give the anti-CD20 is a really good point. So another question related to the use of rituximab in these patients. So when do you redose? And you partially already responded. Do you follow CD19 counts? Do you follow serum immunoglobulins, or the titers of anti-PLA2R antibodies? What is the best strategy in your opinion?
Yeah, well, I'm not the best to answer that, because I'm still using the old-fashioned cyclophosphamide for 8 weeks, and then we can see a response in 70% of the patients, and then we can stop the cyclophosphamide after 8 weeks. So that's another interesting step. But with respect to rituximab, I know from the GEM-RITUX study that it's clear that if you use rituximab and you do not see immunological remission after 3 months, it's not going to work. So then you already could think about redosing. And from the mentor trial, we know that redosing at 6 months is still insufficient for a number of patients, especially the ones who started with very high antibody titers. And that's, I think, very important. So in my view, if you have a patient with membranous nephropathy, PLA2R antibodies, and let's say titers below 100, it's fine with rituximab, and you can use the mentor schedule. Personally, I prefer looking at the antibodies, because if the antibodies are gone, it's fine. So if you measure the antibodies after 3 to 6 months and they are negative, I would not redose. I only would redose if the antibodies are still not completely gone. But yeah, if the antibody titers are high, I would say, okay, you can try to start with rituximab, but if after 3 to 6 months you still have high levels of antibodies, yeah, I'm pretty sure it's not going to work. You can use the mentor schedule, but in mentor, you know, the very high antibody levels, only 40% of the patients responded. So I at least realistically, you would need to rethink, and if you redose, you should discuss with the patient that probably after 1 year, if he is still not negative, there should be additional therapy.
Okay, there's another question on anti-PLA2R antibodies by Dr. Georgalis. Is it possible, if you monitor a patient closely, to see a recurrence of proteinuria before the anti-PLA2R antibodies go up?
Yes, so that's certainly possible, and we have described that patient because, you know, if the antibodies disappear, you expect remission. If the patient comes into remission, then he can have a relapse. But when he relapses, you can have the same as at the initial phase of disease, that the antibodies come very slowly. They bind to the podocyte, they damage the podocyte, but the production level is not high enough to, let's say, to release and have free PLA2R antibodies in the serum. So we have patients where you can see proteinuria going up before the antibodies reappear. On the other hand, we also have patients where the antibodies have gone, but where the proteinuria doesn't, let's say, go down to remission. And in most of the time, you can see in these patients that the antibodies go up again. So then you have an immunological relapse, and the patient you haven't seen any clinical features. So these things are possible. Finally, we also have very few patients, but we have where the patients have persistent antibodies, but still develop complete remission. So I would say, okay, you can use the antibodies to guide your treatment and so on, but be careful. If you have clinical remission, then don't look at the antibodies. So I think as a physician, we should still be aware that clinical features are very important, and we should not just rely on antibody levels. And I'm aware, probably some of you are also working in vasculitis, and we are all aware of patients with vasculitis who have ANCA positive for the rest of their life and never have a relapse. So for PLA2R, it's less frequent, but in our study of, I think, 65 patients, we have 2 or 3 who have complete remission but persistent antibodies.
Okay, that's really interesting. Thank you so much. There's another question regarding antibodies and membranous. So I'm trying to put them together by sort of topic by Dr. Lopez, and asking if you have a membranous glomerulonephritis not associated with antibodies, do you prefer to use cyclophosphamide or a CNI before a rituximab?
Well, you know, I think if you don't have PLA2R, there will be an antibody. The problem is that if you don't have an antibody, you cannot measure a level, so it's more difficult to predict. Yeah, my personal feeling is that probably if the patient has not that severe proteinuria, not that massive nephrotic syndrome, normal eGFR, you can still try what you use in your center. So if you are used to use rituximab, you can do it. But you cannot predict. So it means that after 3 months, you cannot rely on antibody levels to think, do I develop immunological remission? But still, I think if the patient is in a clinical, I would say, acceptable clinical situation with stable kidney function, stable eGFR, and I would say not very severe untreatable nephrotic syndrome, you can choose between tacrolimus or rituximab or cyclophosphamide. And yeah, the choice, I think it's based on what you have, what you can afford, what you have experience with. If you have deteriorating kidney function, or very severe nephrotic syndrome that the patient is getting thrombosis, you have to admit them for furosemide and so on. Yeah, I think the only treatment right now is cyclophosphamide and steroids.
Okay.
That's
Last
personal
question.
opinion.
A last question on membranous nephropathy before we switch gears, and most of the questions were on membranous. What about the use of non-vitamin K antagonist oral anticoagulants, so the more novel oral anticoagulants in nephrotic syndrome? Is that something that we have any evidence on?
No. So in the guideline, but it's not in chapter membranous nephropathy, but I think it's in chapter 1 on the general measures. It's specifically stated that the DOACs have not been tested in patients with severe nephrotic syndrome, which means that we do not advise to use them in that situation. And there have been case reports of patients with severe nephrotic syndrome who developed a thrombotic event while they were treated with a DOAC. I think we need to wait for the metabolic studies and anticoagulant studies in these patients. But obviously, yeah, it depends on the risk. If you have a patient with an albumin of let's say 24, 25, and you are, discussing aspirin, or then maybe if the patient has another reason that you can use a DOAC. But if the patient just presents with a very low serum albumin and you have to start from scratch, it's not the choice that we made.
Okay, great, thank you. Now I wanted to switch to FSGS. Dr. Georgalis asks, does the presence of tip lesions or cellular FSGS exclude a genetic cause?
I'm not sure that there are many data. I'm pretty sure that tip lesion doesn't exclude a genetic form, because in my view, the tip lesion is just a sign of proteinuria, and actually tip lesions you can find in minimal change disease also. So it's more or less how the nephrotic syndrome appears. Obviously, in the adults with genetic FSGS, I think in contrast to children, adults most of the time do not present with a rapid onset nephrotic syndrome. They have this, you know, gradual increase in proteinuria. But personally, I would think that, yeah, the biopsy is not sufficient to exclude a genetic cause. But I have no experience, I must say. I haven't looked at that specifically, but it's my feeling that I would not rely on it. I would rather rely on family history, clinical situation, syndromic features, and so on.
Yeah. Okay. I'm going to ask you a last question because we're running a little bit out of time. There are quite a few questions, so I'm going to try to put them together on the use of CNIs in FSGS and the role of CNI toxicity, and so the interstitial fibrosis and tubular atrophy. In your opinion, is there a score of IFTA, of interstitial fibrosis and tubular atrophy, above which it is counterindicated to use CNIs in focal segmental glomerulosclerosis?
Well, you know, my personal opinion is that a biopsy is nice to have a diagnosis, but not useful to make a score. And that's because I have many experiences that the percentage of IFTA doesn't correlate at all with serum creatinine or eGFR, and that's because you have a lot of sampling error in such a kidney biopsy. So my feeling is that if creatinine eGFR is normal or at least close to normal, let's say eGFR above 60, you can try CNI. If you have a decreasing eGFR, you should be very careful. And especially you should not accept further decreases of eGFR, because I think that's something what's happening, that people start to see increases in creatinine and then they accept it. But you should realize that, you know, if a kidney has, you know, reserve function, that any increase of creatinine is already problematic. But I mean, we allow 10 to 20% increase, but yeah, I would be inclined to stop early if I see that happening. The other point is that in the study which I showed is that these patients were treated for a long time with immunosuppressive therapy, and we had at that time often that we used CNIs, but also we have used a lot of cyclophosphamide and MMF. And going back now to the data, we noted that the patients who had, let's say, partial remission, many of them, that the patients who had used CNIs had a lower eGFR than the patients who were treated with cyclophosphamide and MMF. And obviously they had been treated with CNIs sometimes for 1, 2, or 3 years. And yeah, I think personally that I'm in favor of using CNIs in such a patient if you want to start with it, but maybe we should be reluctant to use it for more than 12 months. And also with my experience now, outside COVID, I think I would prefer MMF if I really think it's primary FSGS. If I am in doubt, and I think it could be also, you know, maybe genetic or something, then I would prefer CNI. But I think it's still open. We need to have studies, but I think there is no real cutoff point for CNI. I think the baseline kidney function is important, and any change. So you should not accept major changes in eGFR.
Great. That was really, really helpful. And I'm going to ask you just one last question because it just came through, and I think a lot of people will be curious about this one. And then I think we really need to move on because we're a little bit over time already. And it's about the use of SGLT2 inhibitors in proteinuria of patients with glomerular diseases.
Okay. Well, you know, so this is not in the guideline, luckily, but I can share my personal opinion. So I think SGLT2 inhibitors are good drugs in patients with diabetes. They are probably good drugs in patients with secondary FSGS. And I would like to comment on the IgA study on the DAPA-CKD and IgA that were not patients with IgA nephropathy, that were patients with long-standing IgA likely secondary FSGS, not active IgA. And in patients with secondary FSGS and proteinuria, SGLT2 inhibitors are probably good drugs, but I'm not sure that they are better than other antihypertensive drugs. That has not been proven yet, I think. They lower proteinuria and they lower blood pressure, that's fine, but that's what we think. And if a patient is treated with, I would say, ACE inhibition, ARBs, diuretics, spironolactone, and they have a low blood pressure, I know that some people then advise to stop thiazides and spironolactone and add SGLT2. In my view, there is no proof that that's better. So if a patient is stable on antiprotein therapy, it's fine. If a patient has still reasonable blood pressure above, let's say 120/70, 130/80, has still residual proteinuria, you could add SGLT2 and see whether the proteinuria drops. But I must remind you that this is for secondary FSGS. It's not for patients with nephrotic syndrome.
Okay.
And
So
I see no place for SGLT2 in the initial treatment of patients with nephrotic syndrome due to any of these glomerular diseases.
Okay, I think that's important to say. Okay, thank you so much, Jack. So there are a couple more questions, but since we don't have time, I can say that people can contact directly Professor Wetzels if they need. And I would also remind that he's an adult nephrologist. There were a couple of very specific pediatric questions that are a little bit outside the realm of this webinar, which is the reason why I didn't run through them. So thank you so much for to all the participants, and especially to you, Jack, for this really, really interesting overview of the KDIGO guidelines. Looking forward to seeing you all soon, and thanks again.
Thank you, Marina, for sharing. Thank you, Stephanie. Thank you, the audience. It was a pleasure. Bye-bye.
Bye, thank you.